If we talk specifically about idiopathic intracranial hypertension, it is more common in young ladies who are overweight. Very few cases have been reported in men as well. So if we talk generally, patients who have high BMI or have recent weight gain are at higher risk. You know what? Pseudotumor cerebri or idiopathic intracranial hypertension is considered as one of the feared topics among students. But actually, it's not that tough. All you need to know is about raised intracranial pressure, because all the signs and symptoms of pseudotumor cerebri are because of raised intracranial pressure. So let's get to know that how this clinical condition presents in the clinics. You know that symptoms are the complaints that patient tells us. So the symptoms in this case are nausea, vomiting, headache. So the first and foremost complaint of the patient is headache. It is present in almost all of the patients. It is generally diffuse and non-specific in terms of location, frequency, and type. But yes, it is worse in the morning and aggravated by Valsalva maneuver, coughing, or any act of straining. It is very important to know that patients tend to get temporary relief from NSAIDs just like in any type of headache. So they tend to use more and more analgesic medication, which may lead to superimposed another variety of headache called medication overuse headache. Patients can experience double vision. This is a symptom of false localizing cranial nerve 6th palsy. So this is another problem with high intracranial pressure. There is horizontal displacement of images, and if we check eye movements, there could be limited abduction in one eye or both. Pulsatile tinnitus. There is rhythmic ringing in the ear which seems synchronized with the pulse. It is believed to be vascular pulsations which are transmitted by high pressure CSF to venous sinuses. So patients can listen these pulsations continuously, and it's quite an annoying feature, isn't it? Next is transient visual obscurations. Patients report as sudden dimming or graying out of vision while rising from sitting position or lying position, which lasts for less than 1 second. Patients describe it as something cloudy appearing in front of their eyes, which then vanishes away by itself. You know that signs are the features that we physicians elicit in our clinics. An optic nerve is the second cranial nerve, and it is the main part of the visual pathway. So the sheet around the optic nerve is in direct continuation with the subarachnoid space in the brain. So any increase in the pressure in CSF is directly transmitted to the optic nerve. So most of the signs and symptoms in pseudotumor cerebri are because of involvement of optic nerve. The diagnostic hallmark of pseudotumor cerebri or intracranial hypertension is swelling of optic disc or optic nerve head, which is called papilledema. You must have learned how to examine optic nerve during cranial nerve examination in neurology, so here comes its practical application. We are trying to look for all the signs of optic nerve involvement and finding is there papilledema or no. So we look for visual acuity. We check it with the help of Snellen's chart. It is usually normal until patient has very severe papilledema. The vision of the patient starts deteriorating only in advanced cases. So that's a good point. We also do visual field examination or perimetry. When we examine visual fields, we may find loss of peripheral vision in one or both eyes. It leads to constriction of visual fields. Firstly, it starts with inferior nasal quadrant, which then progresses inwards. Similarly, we can find enlarged blind spot, which is a feature of papilledema. Although less common, but sometimes there is blurring or distortion of central vision. This is because of macular wrinkling or swollen optic disc. We also look for color vision. Sometimes there is reduced perception of colors, but remember one thing, that color perception is a characteristic of central vision, so it affects late in the course of disease. And very importantly, we do fundus examination. When we do fundal examination, initially we can see hyperemic disc, and with time or if raised intracranial persists for longer duration, we find blurring of optic disc margins and optic atrophy in very late stages.